we take off a bile duct here, and if I were to do, we've kind of talked about prior to surgery, if I were to do the normal reconstruction, we actually just cut this off and sew it right there.
Right.
And I told you that your duct there was a size difference, and it looked just a slight bit different, so I figured we would not do it. But there was nothing funny about it, nothing that looked abnormal or whatnot. But quite unexpectedly, when they called us from the pathologist, they saw a small little mass that's kind of like right up here, actually. And then they saw, which was high-grade dysplasia, and then they saw high-grade dysplasia.
But that's
that
come
went
out.
down. This is all out.
That's
Yeah,
come out.
this is out with your old
the
liver.
Surgery.
So this little spot was dysplasia, and then there was some dysplasia that went down the duct, and there's a little bit of it that involved this cut edge of the liver.
Mm-hmm.
So what's left is the duct that goes through your small bowel to your pancreas,
Right.
and there's there's enough up here that I could sew it with stitches, basically. So that's not very much duct, but a little bit. And your new anatomy, I should let you draw all my pictures, these are great. Your new anatomy, this is kind of out of the picture, so it's not seeing bile anymore. It's really doing nothing, it's just sitting there. And this is your new anatomy, and this is your donor's bile duct, so all this is normal and sewn together. And we looked at that with that study when you went downstairs and had the radiologist do the study. So this whole part we're not worried about at all. The question is, what, if anything, to do about this? And I don't think anybody has a perfect answer. It's not something that we see often.
But that's not doing anything.
It's not doing anything.
But it's precancerous.
It's precancerous.
There is some extent. We don't know how
We
far
don't know
down
how
it's
much.
extending.
It
Yeah.
could be that I cut it right at the edge of it, and what's left is not cancer at all. It could be that it's going, if I went back and tried to really core out and get this tiny little sliver, meaning a millimeter or two, then it would say it was negative. Or it could be that I could go as far down as I
And if you
can,
still see it, then you got to.
and if I still see it, then I have to take out the whole head of your pancreas,
Oh my God.
which is a really big operation. That means taking out all this bowel, the head of the pancreas, and
Holy shit.
what that could put you at a risk of a number of things. So one is diabetes. So you don't always get diabetes from taking out the head of the pancreas, but there is a higher risk if you take out the head of the pancreas. Also, the pancreas makes pancreas juices. Pancreas juices, that connection has a risk of leaking. It's a higher risk of leaking than any of the other connections that we made. And unfortunately, if that leaks and it drips onto all the other connections that we already made, that can be a risk for those connections. So there's no problems with them now, but if this were to happen, it were to leak, it could cause problems with those connections too. So it's not a benign operation to put you through. And so the question is, what if anything should we do about it? Option one, and again, I don't think we fully know the right answer. We've had a lot of email conversations sort of over the weekend with people here, as well as I talked to the folks up in Rochester. They do a lot of PSC, a lot of cholangiocarcinoma, including, I know you guys do a lot of research. So Greg Gores is the big hepatologist that has done a lot of cholangio work, and I just got a message from him this morning as well about your case. One option would be to just do surveillance, meaning we know that there might be a little bit there. We do CT scans, maybe endoscopies to look at that spot and see if anything were to come up. If something were to come up, then we would go back and talk about a big operation. Favorable to that approach is Dr. Gores believes that defunctionalized, meaning the fact that this isn't being used anymore, is less likely to progress to cancer, meaning that if it's not seeing bile and it's just sort of sitting there, it's less likely to have a progression to cancer. High-grade dysplasia doesn't hurt you at all, and you probably would never know what was there. Option two would be to have our endoscopist come in and try to burn this, and they may or may not be able to do that from the inside. So they would go in, look, and they would potentially try to clean up that area with we call it burning. It's not quite, burning is a fancy word, it's photocoagulation, but it's
Right.
basically burning. We talked to our endoscopist here in Florida this morning. They don't do it here in Florida. I did send a message up to one of the endoscopists in Rochester to see if they had any experience or any interest. It would obviously mean a trip to Minnesota for you guys, which nobody wants to do in the winter. And it's not an urgent thing. It's not something, again, none of this necessarily needs to be done today, tomorrow,
Right.
even 6 months from now. But I did send a message to them to see if they have any experience with that or any thoughts or options about that. Then other options would be to surgically take you back to the operating room, either in the short term, within the next few days to weeks, or 4 or 5 months down the road. Start with trying to take out just this bile duct. If we got that negative, we would take that out and we would be done. But potentially proceeding all the way to the Whipple operation, which would be a week in the hospital. And we're not sure we're helping you or not, and all the inherent risks of that operation.
I think the surveillance is the best option.
I'm leaning in that direction, but I wanted to have a discussion with you. And again, we don't have to decide today.